I'm Cami Hubbard. I am a dietetic intern at Carolina Healthcare System Northeast, and this is a clinical nutrition update and case study of chronic obstructive pulmonary disease and acute respiratory distress syndrome. To start off with some terminology, COPD is a chronic inflammatory lung disease causing obstructive airways from the lungs, including bronchitis and emphysema. So bronchitis is increased mucus and inflammation of the bronchi, and emphysema is damaged and enlarged alveoli. We'll talk a little bit later about why that's so impactful. ARDS is acute respiratory distress syndrome. It is caused by the symptoms of COPD, and it is the fluid built up in alveoli, the air sacs in the lungs, that lead to a decreased oxygenation of the bloodstream and thus decreased oxygenation of muscles and tissues throughout the body. Pulmonary cachexia syndrome, or PCS, is a loss of fat-free body mass causing muscle wasting due to tissue hypoxia, distress or disuse atrophy, oxidative stress, inflammation, medications such as glucocorticoids, changes in the metabolism or intake, and malnutrition. So people with especially end-stage COPD are more at risk for pulmonary cachexia syndrome, just because of changes in metabolism, increased nutrient needs, as well as a decrease in intake due to shortness of breath and just the inability to eat because they're of difficulty breathing. So some anatomy, you got the trachea, which is the windpipe, leading to the bronchus, which branches into bronchioles, and down to respiratory bronchioles. At the end, there are alveoli, which are the tiny sacs involved in gas exchange. And then the pleura is the serous membrane that lines the lungs. Corticocorticoids are endogenously secreted by the adrenal glands. They are also exogenously given to inhibit inflammation. They're often used in asthma or autoimmune disease treatments. Examples of those include prednisone, dexamethasone, hydrocortisone. As you know, while patients are on steroids or any kind of glucocorticoids, it's important to monitor hydration as well as blood glucose because of their effect on pancreatic alpha and beta cells. Many times patients can have uncontrollable blood glucose levels as a result of these medications. Hypoxia is an inadequate amount of oxygen reaching the tissues. And as I mentioned earlier, there's the respiratory membrane at the alveolus and pulmonary capillary membrane, or the contact with the alveolus and pulmonary capillary. This is where gas exchange occurs. And hemoglobin is a protein with 4 subunits, a central iron atom, which is normally found in its 2+2 redox state, known as ferrous, and this can reversibly bind to oxygen and thus carry it throughout the body to transport oxygen to tissues and cells. Oxygen saturation is when oxygen is bound to the hemoglobin, and this is a dissociation curve that is showing the function between oxygen saturation and the partial pressure of oxygen. So as the partial pressure, which is the pressure exerted by the oxygen in arterial blood, as that increases, the oxygen saturation of oxygen into hemoglobin also increases. In normal physiology, oxygen moves across respiratory membrane into arterial blood and is carried by hemoglobin to the tissues. This diffusion occurs naturally as the partial pressure of oxygen decreases from dry air through the tracheal air, alveolar, the arterial blood, and to the tissue. So the partial pressure of oxygen is involved in this uptake as oxygen moves down that gradient. This exchange takes place in the capillary network of the alveolus. But when things go wrong, the pathophysiology includes the inability of adequate oxygen exchange due to inflammation, fluid buildup, and alveoli enlargement. So these are 2 images of emphysema and bronchitis. For bronchitis on the right, you have this inflammation and this thinning of the narrowing of the bronchi, and thus it's harder to get oxygen through. And then on the left, you have emphysema, which actually involves alveoli enlargement. And if you think about surface area to volume ratio, if your volume is getting bigger, but your surface area is not proportionally, then you have inadequate and ineffective gas exchange. So the smaller the volume, the better ratio you have for more effective gas exchange. This inability to adequately perform oxygen or gas exchange leads to hypoxia, hyperventilation, coughing, shortness of breath, weakness, dyspnea, and increased energy needs. Risk factors for COPD and thus ARDS are smoking or exposure to tobacco smoke, asthma and smoking, prolonged exposure to inhaled irritants, exposure to fumes from burning fuel, increased age, and a genetic propensity. Then once you have COPD, complications include an increased risk for respiratory infections, including influenza, pneumonia, the common cold, also an increased risk for heart disease, lung cancer, pulmonary hypertension, and even depression. Recommendations and evidence-based practice include the focusing on prevention and treatment of weight loss and comorbidities. So you want to really monitor that weight and that protein and muscle mass, because they're at an increased risk of losing muscle mass, like I mentioned, the pulmonary cachexia syndrome, PCS, and also weight loss because of the increased needs and many times the decreased intake, or because of possible shortness of breath or just not even able to meet those energy demands. In advanced stages, you normally have a disturbed energy and protein balance. And as you know, caloric and protein malnutrition lead to increased mortality, respiratory muscle dysfunction, prolonged dependence on mechanical ventilation, and increased susceptibility to infection, which can be really hard when you're also dealing with, you already have a predisposition for respiratory infection. So also another note about needs with COPD is to avoid overfeeding patients that are on ventilation. So many times due to a COPD exacerbation or status of ARDS, patients are placed on ventilation. This reduces the caloric requirement and also caloric expenditure. So you really want to avoid overfeeding these patients to also avoid putting that extra stress on the body because of the increased CO2 production in metabolism. Further research is needed for a target caloric need, but of course, indirect calorimetry is preferred, but it is costly and not likely to occur in the clinical setting. But then they do recommend following critical illness guidelines for energy needs. Early enteral nutrition between 24 and 48 hours is encouraged, and you're to aim for about 80% of goal energy needs. As far as ventilated patients, they recommend finding the Penn State equation for predictive equation of energy, and then going for 50 to 70% of those needs initially while the patient is on the vent. The EAL says to use predictive equations to assess the energy needs and be sure to account for inflammation. Nutrition supplementation is encouraged to increase energy intake and weight maintenance, as needs may be higher during hospitalization. As far as protein needs, obviously also following critical illness guidelines, and I'll show you some of those guidelines that were followed in my case study. For energy needs, use the predictive equations of the Penn State 2003B and Penn State 2010, depending on the BMI and the age of the individual while they are on mechanical ventilation. The multidisciplinary team is very variable for each case of COPD, but most likely includes pulmonology, case management, SLP, infectious disease, considering the respiratory infection risk, dietetics, physical therapy, social worker, especially when many patients are headed home on some kind of oxygen. So making sure that they're equipped and they're able to get the oxygen and equipment that they need. Physical therapy is also really important when they get home to prevent that cachexia. Supplemental oxygen is used for hypoxic patients, including nasal cannula, CPAP, BiPAP, and then, of course, invasive ventilation in some cases. So steroids, antibiotic therapy. In outpatient nutritional therapy, it's important to incorporate some kind of exercise or other anabolic stimuli to make sure that those protein, that protein goal is being used to increase muscle mass and preserve muscle mass, to avoid getting to a point where you are in a cachexic state. Also, anti-inflammatory treatments are kind of on the cutting edge, so they're looking at using these anti-inflammatory nutrients to kind of avoid this inflammation process and reduce the inflammatory process of COPD and ARDS. So omega-3 fatty acids are recommended, and also just a well-balanced diet. So really replacing a lot of those inflammatory pathway fatty acids with the anti-inflammatory pathway fatty acids, and just overall providing a well-balanced diet to the individual. During mechanical ventilation, many times patients are proned. This is something that was first introduced in 1976, and it's used as a strategy to improve oxygenation through improving ventilation perfusion ratio. So that's the amount of air that's getting to the alveoli. If you think about it, when a patient is in the supine position, according to gravity, most of the alveoli that are being used, it's the same alveoli all the time, but being able to prone the patient introduces new alveoli to this gas exchange, being a part of the gas exchange. And so really mixing things up and getting all the alveoli engaged, so they don't lose function, and so that respiration is improved. Note, this is not obviously safe for those who are hemodynamically unstable. Many times there is a 10% incline to decrease facial edema or the risk of intra-abdominal hypertension. Even in that case, a lot of times patients are still experiencing a lot of facial edema or even pooling of blood, maybe some bruising in the face, just because many times it's for several hours that they're proned. But it has been shown to increase oxygenation and be effective in that way. Enteral nutrition is feasible and safe during proning. It has been shown that way by specifically a study that I did reference in this PowerPoint, but there should be no hesitation to continue enteral nutrition while the patient is being proned, unless, of course, there are other indications, as always, while monitoring tolerance of enteral nutrition in individuals. So if gastric residual volume skyrockets or there's a lot of vomiting or anything like that, obviously, while monitoring tolerance, it is safe and feasible to continue enteral nutrition during proning. This is my case study, Miss S. She is a 70-year-old female with type 2 diabetes that was admitted with fever, weakness, and shortness of breath. So it seems kind of small, but it can be kind of scary when someone has a history of COPD when they come to the hospital with weakness and shortness of breath. So she was transferred to the ICU with hypotension and hypoxia. She's found to have acute respiratory failure, sepsis, metapneumovirus, pneumonia, flu, COPD exacerbation, and a UTI. You can see that she was already at risk for respiratory infection, and in fact, she was found to have 3 respiratory infection issues going on here. So her body is already overwhelmed due to her predisposition for that, those illnesses. She's 5'2", 70 kilograms. According to the BMI standards for those above 65 years old, she's barely overweight at 140% of her ideal body weight. This is a good thing that she's not underweight at this point because of her risk factor for PCS. So it's hard to gauge the muscle status of individuals with this BMI, but at least she's not, she doesn't have any stores. She has some stores. So her history is COPD, type 2 diabetes, chronic AFib, PVD, recent diabetic leg infection requiring skin grafts, so she has an increased need for proteins, DCHF, AFib, coronary artery disease, dyslipidemia, hypertension, and smoking. On day 1, I actually got a screen for suspected malnutrition for low serum albumin. When I looked her up, I found that she did have a pressure ulcer, so I would rather have been screened for a non-healing wound than low serum albumin, but I went and talked with her. She was alert and oriented. She appeared well-nourished with pale skin. She reported good appetite and intake prior to admission. She was consuming well that day, that day per the RN. Noted that she had a pressure ulcer stage 3. I performed a nutrition-focused physical exam with no significant findings, but did provide a Glucerna supplement, which I'll talk about in a second. These are her vital signs. She's a little low in potassium, a little high in her blood glucose, but I was impressed with her A1C. As a type 2 diabetic, she seemed to be controlling it well. Her urine output was good. This is not the entire day, so it's looking good. Those are her meds. She's on Humalog moderate for her diabetes. Consistent carbohydrate diet. I estimated her energy needs based off of 25 to 28 of her current body weight, 1.5 to 2 ideal body weight due to her non-healing wound. And she was eating well, so there wasn't a big problem. I diagnosed her with increased nutrient needs due to the wound and recommended she eat greater than or equal to 75% of her meals. Added a couple Glucerna to try to make sure, especially if her appetite decreases with the shortness of breath, she's still getting the nutrients she needs, and I plan to follow up with her. Day 2, during rounds, I noted that Miss S had been intubated due to shortness of breath overnight. And it was complicated, obviously, with the metapneumovirus influenza and now shock related to hypovolemia or sepsis. The nurse today noted that it was probably more like a pressure ulcer stage 2 than stage 3, which is interesting to me that it's based on what the nurses say. So it actually changed a couple times during this case, but she was having good bowel movements. These are her vitals for today. Her blood glucose is still very high, and you might notice that the BUN is now abnormal. She has continued to have all of her output is urine output, so that's good. She was put on NPH and Humalog high to better regulate her blood glucose. Levothyroxine by mouth, which is important to consider while giving enteral nutrition, because any food in the digestive system can actually decrease absorption of levothyroxine when it's given by mouth. So I'm going to incorporate that in my enteral nutrition recommendation so that she's not eating at that time. Also, she's on propofol, so that's something else to consider when giving my enteral nutrition. I'm going to initiate enteral nutrition through her oral gastric tube. I did decrease her energy needs from 20 to 25, but I kept her protein needs at 1.5 to 2. I want to caution overfeeding while she's on the vent. Caution against that. Added a diagnosis of inadequate oral intake, obviously, because she cannot eat while she's on the vent and intubated. Then I decided to start pivot 25 at 25, increase 10Q4 for a goal rate of 45 over 22, I'm sorry, 45 over 22 hours, because I want to give an hour before and an hour after the levothyroxine with 25 mils per hour water flushes. With the propofol at 4.2 mils per hour, she's getting 1596 kcals, 93 grams of protein, and 1351 mils of free water. Day 5, this is over the weekend. Patient remains intubated and sedated. She's not making any vent weaning progress, and she continues to have issues with influenza, adenovirus, ARDS, pneumonia, COPD. She has an AKI and new left bundle branch block. So basically that left ventricle is not in sync with the right ventricle, which is actually contributing to greater shortness of breath. She has anasarca and edema on her left hand. continues with that pressure ulcer stage 2. And she's also not tolerating tube feeding. She has 580 mils of residuals, so tube feeding is now held. You can see that her kidney function is declining. BUN and creatinine are not looking great, and her potassium is very high. All of her urine output is 75 mils. She was put on Miralax and mag sulfate. She was also put on Endotool because we want to start monitoring her blood glucose more closely. I recommended that we resume tube feeding when the MD permits or believes it's safe again. So when we do that, we're going to start at 25, increase 10Q at Q4 for the same goal rate. And we're going to be providing the same number of kcal minus the propofol. She's now off that, but I'm going to continue with the same goal. Day 8, patient is still intubated and sedated. She's being proned. She was proned yesterday, and she's going to be proned again today with worsening hypoxic respiratory failure. The patient is also experiencing acute renal failure, so she's now on CVVH. And we're questioning a GI bleed because it was found that she had coffee ground output in her OGT and FlexiSeal. Tube feeding was held because of high residuals, but is now resumed as of yesterday. She continues to deal with influenza, metapneumovirus, pneumonia, ARDS, and septic shock. Palliative care is now on board because her case is becoming less fortunate by the day. She has anasarca, bilateral scleral edema, bilateral facial edema, mostly because of the proning, and now pressure ulcer stage 3 in multiple skin tears. Real quickly, continuous veno-venous hemofiltration is this temporary continuous renal replacement. So it's basically she can't go through hemodialysis, in these quick 4-hour time periods. This is continuous. She's always on this, and this is really just relieving a lot of pressure from the body because of her fluid overload and acute renal failure. Just doing the filtration process for those kidneys to kind of take a little pressure off and reduce the fluid overload. As you can see, her BUN and creatinine are still, now they're improving a little bit due to that CVVH, and most all of her output, a large percentage of her output is that ultrafiltration. She did receive 3 units of packed red blood cells and 1 unit of platelets. So not only to just improve that blood quality, but also hopefully improve that oxygenation of the tissues as much as possible. She's put back on Humalog high now that she's off Endotool. I'm going to continue pivot trickle feeds with no flushes, and then increase that to the goal of 45 mils for 22 hours once again, just to continue that 1485 kcal and 93 grams of protein. She, day 9, remains intubated and sedated on 2 pressors. She was proned until 6 this morning, but is now supine. There's no plan to prone her again. It doesn't seem to be really being as effective as, or improving things as much as they would like it to be improving. She is now DNR as of yesterday and continues on CVVH. They started back the tube feeding to advancing it slowly, and they mentioned in rounds that she has a fairly poor prognosis right now. Palliative care is following her. She still is experiencing anasarca and bilateral preorbital edema, still has that pressure ulcer. So once again, her urine output is very poor, 10 mils, and most all of her output is the ultrafiltration with the CVVH. She's still on levothyroxine by mouth, but is not on propofol. So I recommended increasing that to the tolerated rate of 45. Once again, just keep, as much as we can, let's try that. If it doesn't work, let's go back to the 10 mil trickle feeds just to give her something, because it's very unfortunate that her body's not receiving it well. The power of attorney, which was given to her grandson, he was informed about her prognosis and was encouraged to reach out to pastoral care and family and friends that are close to Miss S, just to really determine what would be best for her in this situation. So we were unsure where this would go, but it looks like the predisposition that she already had with COPD led to this increased risk for multiple respiratory infections, which really put her in a place where it led to multi-organ dysfunction. And at this point, there's not a lot that can be done to reverse that. So it's very sad to see the effect of, COPD in ultimately leading to a really bad place. And nutrition was really important in that, and preserving any muscle mass that she had, and also promoting, good caloric energy needs and provision of that. But it just became very complicated when multiple organs began to fail. Our multidisciplinary team included the critical care team, pulmonology, endocrinology, cardiology, pharmacology, wound care, dietetics, infectious disease, nephrology, case management, social work, and pastoral care. These are my resources, and that is it for my case study. There's so much more about COPD and ARDS. I started reading more about gas exchange and all kinds of things with the respirator and ventilator and all this stuff. And it is so complicated. I'm really glad that pulmonology has a lot to say in ICU. But there's so much to learn, and it's very related to the overall health and status of the individual, which has massive implications on the need for and the use of nutrients in a person's body. So thank you for listening.